So let me quickly introduce our three panelists, starting right here on my left. Oops, I have the wrong panel. Sorry. Kathryn Hall, who is PhD and is Deputy Commissioner for Public Health and Equity at the Boston Public Health Commission, which is part of the government of Boston, and is deep into what's happening here in Boston, and a lot of information you're going to learn from her. Dr. Rachel Villanueva, who is an OBGYN and also was just stepped down as the president of the National Medical Association. And I love its description, so I'm going to read it from your bio. The collective voice of African American physicians and the leading force for parity and justice in medicine and the elimination of disparities in health. That's an ambitious goal. Good for you. And thank you for doing that. Finally, Simmone Taitt, an entrepreneur who is founder and CEO of Poppy Seed Health. Maybe you should just quickly say what Poppy Seed Health is so I don't mess it up.
Oh, sure. So we connect people in 90 seconds or less to doulas, midwives, and nurses for all their emotional and mental health support needs.
Oh, that's very succinct. Thank you.
Thank you.
So I wanted to start out by asking each of you, why do we need to be talking about healthcare equity? And Kathryn, if I could start with you, why is this a critical topic?
Well, I think we all agree that COVID revealed all the underlying problems in healthcare that have been driven by structural racism across the country. And structural racism, obviously has influenced us through poor education, economic adversity, poor access to healthcare, and of course, as we're talking about today, low access to technology. And with COVID, people in historically marginalized communities that have been the victims and the targets of racism have ended up having much higher rates of various diseases on top of the chronic diseases that we've seen before and the infectious diseases before. And so this is not just impacted the people who are directly affected by this, but really impacted us all because we all live in an ecosystem together. And if one of us is not well, really and truly, I think it affects all of us.
Wow, that's quite eloquent. Rachel, what do you think about the reason why we need to talk about this?
I'm not sure there's anything else to be said after that. But, as I think COVID was a great example. I think I'm an OBGYN, so the maternal health crisis in the United States is another example of why we need to talk about health equity. For those of you who may not know the statistics, Black women die 3 to 4 times the rate of white women in the United States in pregnancy-related. Yes, wow, exactly. That's a wow, right? We're in the United States is the worst of all industrialized nations in maternal health statistics. In
overall statistics.
In overall statistics of death in pregnancy, during pregnancy, yes.
Good for us. We're really, okay,
right.
Go on.
So I think, as you read what the NMA is about, the NMA was founded in 1895. When segregated laws meant that Black patients could not go to a regular hospital and Black physicians couldn't practice. So we've been dealing with this for a very, very long time, and we see the effects of the inability of people to access routine basic care, and we see what happens when health equity predominates in our society. So I think this is a very important group, probably a group that doesn't get to hear about health equity all that often, and maybe not particularly interested right off the bat, but I think very important conversation to be had.
Right, and as Kathryn said, it is all of our concern. So Simmone, what do you think?
Yeah, when it comes to innovation, which I think everyone can agree in this room, we're here talking about innovation all day, every day. I think about innovation as accessibility and equity. That's what it equals. And so you cannot have a conversation about equity without also talking about accessibility, also talking about affordability. And if those things aren't baked into the innovation and the things that we're making decisions on and spending a lot of venture money on or a lot of your P&L on, then what is it that we're doing? And I think especially as it relates to where we are today, we're at a very important inflection point as it relates to health and wellness, behavioral health, and what it means for us to have a more integrated viewpoint on how and who we are serving. Equity is the core of everything that we should be doing, period.
So what is the problem that Poppy Seed Health set out to solve? And tell us a little bit about how you're doing.
Yeah, sure. So I'll just quickly tell you the background story, because I think that our own lived experiences are so powerful in the solutions that we're building. In 2016, I had my first pregnancy loss. I've had multiple since then. And I found myself in that very first one a few years ago, fending for myself in a very complicated maternal health care system, one in which I didn't know at the time women who looked just like me, Black and brown women, and the deep racial disparities in maternal health care were affecting me and the kind of care that I was getting. So much so that I left that appointment with no medical follow-up, no emotional or mental health support. I became a doula myself, specifically to be boots on the ground as a non-clinical provider, to be collaborative and really understand what was happening across the full spectrum for better health outcomes. It was very obvious that in the US, we do not center on or ground in or even integrate emotional or mental health support into the maternal healthcare experience, prenatal, postpartum, or when you're experiencing loss, even across our entire reproductive healthcare journey. And that is the biggest problem that we're solving today. I often say at Poppy, we are feelings frontliners. So we establish trust and safety first with folks, and because of that, we end up understanding so much of what's actually happening with what is happening with their bodies and themselves, but mostly around their mental health support needs and their emotional health support needs. And I will also say that we're very proud that we baked into our business model from day zero serving Medicaid. So in our first year, 30% of everyone that comes to Poppy Seed Health are Medicaid. They are also primarily 10 weeks or less pregnant, which is huge. They're usually not even in the system yet.
So just quickly, since the theme is how digital helps all this, how is digital coming to play with Poppy Seed's system, really quick?
Yeah, sure. So very quickly, one of the things that we've learned with our data, and we have a really robust back end there for anyone who wants to chat about that, maternal healthcare deserts are on the rise, and they have been for quite some time. Primary healthcare deserts are on the rise. Very specifically, what that means is that someone lives 90 miles or more from their closest provider, clinic, or hospital. So they're living in what is the majority of our beautiful country, rural America, and they do not have access to the kind of care that they need. And so at Poppy, not only does this affect about 7 million people across the country and over 1,000 counties in these maternal health care deserts, but since our inception, we've actually been able to connect with over 40% of our population today. They live in those deserts, and we know where they are because they're self-reporting on it. We're able to tag them, et cetera. So equity also means where folks are, what they have accessibility to, and of course all the SDOH things that we're addressing with them in these one-on-one conversations.
Okay, I want to come back to Kathryn in a minute with some big picture questions, but while we're on the maternal side, I want to go to our OBGYN here and talk a little more about, from your experience, how inequity is manifested in maternal health and in the issues that you work on.
Well, I think if you just look at the statistics that I just mentioned in the opening, right, we're looking at 3 to 4 times the death rate for Black women or non-Hispanic Black women. When you look at these statistics, the disparities in maternal health have persisted in the United States for over 100 years. And these statistics aren't getting worse over time. As we are spending more and more dollars on healthcare, we are becoming less effective in treating or taking care of women during a very routine, what is a routine process. It was a process that used to take place and now still does in people's homes or in birth centers. It doesn't necessarily need to take place in a hospital. So we see that disparities in care are negatively affecting Black and brown women disproportionately. And it's not the scenario where they're not taking care of themselves, they're uneducated, because we see that being educated doesn't protect you. College-educated black women die 5 times the rate of college-educated white women in the United States, and that a college-educated black woman will die 60%, have a 60% more likely chance than high school-educated white women of having a pregnancy-related complication.
Are those disparities, to what do you attribute those disparities? Is it literal racism
Yes.
in the hospital system?
Yes. And I think Kathryn touched on that in the very beginning. I think we know that we talk about and we heard about during COVID the social determinants of health really impacting why some people did poorly with COVID with the same exact disease processes, with the same exact medical care. Some people did much worse than other people. So we know those social and economic drivers are a very significant cause of health disparities. But underlying all those social and economic drivers is racism and discrimination. And unfortunately, the healthcare system is not a vacuum. It's not like everywhere else there's racism, but when you come to the hospital, everyone's nice and loves you, and that's great. That's not the case. And we know that research is very well documented that, and this has been going on, the documentation of poor health outcomes just based on race, nothing else, not socioeconomic status, has been documented since the 1980s. Health and Human Services documented why minorities, black individuals, were dying disproportionately. It was followed up in 2003 with a very well-known report called Unequal Treatment, that just race and ethnicity is a primary driver of poor health outcomes. So unfortunately, which is what makes it so difficult, that we still live in a society and in a healthcare system that was based on unequal treatment for people in the very beginning. And unfortunately, it hasn't gotten much better. And so we continue to see these disparities exist. And that's the goal. We're trying to eliminate those disparities and reach health equity.
Thank you. Well, Kathryn, I know you have a lot of experience and thought about how some of the new tools, which we've been talking about all day today, data, et cetera, can really be brought to bear to address some of these issues. So talk a little bit about some of the things you've learned here in Boston and in your own work.
Certainly, I think the story that COVID tells is really emblematic of health equity and the struggles that we have. So, firstly, you can imagine COVID hits Boston, and I think Peter said it, that he made the Paul Revere reference. Our first commissioner at the Boston Public Health Center was Paul Revere. So we argue that we're the oldest public health commission, but we are arguably not the best, right? Because we haven't done, or we're just in the process of doing data monetization. So when I started at the commission, the first thing we had to do was think about how can we address the problems that we're seeing today with the same staff that we have, knowing that there's the great resignation happening and it's really hard to get tech people in. We have data coming in from cases, data coming in from the wastewater, data coming in from the hospitals, data coming in from vaccinations. How can we put that together on a dashboard so that people can understand it? And the people who need to understand it are not just the city government's people or the hospital people or the Department of Public Health for Massachusetts people. It's the residents of Boston, the community leaders and the people in the community themselves. So we had to create this kind of like democratic way of sharing data and sharing information. So I think that the technical challenges were everywhere in front of us. And we made ourselves into the Public Health Science, Technology and Innovation Center. And there we literally set up wastewater analysis and integrated the data. We used machine learning. Somebody mentioned that we haven't mentioned that enough, so I thought I'd mention it. But we used machine learning to ask what is happening on a national level, what are the drivers of people getting severe illness with COVID, and what happens when we look at those drivers that we see on the national level using fancy machine learning and AI clustering analyses. What does that tell us about the Boston experience? And it's amazing what we learned and amazing what we're learning using that approach. At the same time, we had to get information to people, and there's a huge infodemic. I think everybody knows that this vaccine hesitation or vaccine hesitancy is such a critical blocker to people getting the drugs, Paxlovid, for instance, or the vaccines that they need to protect themselves, even the mask that they need to wear. There is hesitancy around it, and we know that this is being driven by unseen forces, and so we have to figure out from a digital perspective, how can we reach people who may not have a smartphone or may not have broadband access. It's known that in Boston, this report just came out today, that over 30,000 homes in Boston don't have broadband access.
30,000 homes.
30,000 homes. There are 680,000 people in Boston. So that's a high proportion of our homes that don't have this access. And when people went home for their education, their home or for their work, they still needed to work using their broadband. So this also creates problems that drive health inequity.
Yeah, inequity emerges in surprising ways. Really? Okay, we're going quickly. I know you mentioned the wastewater, and Boston was the pioneer in the country in evaluating wastewater to try to identify COVID. But you mentioned that even in wastewater analysis, there is discrimination. Can you explain that a little?
There are disparities in our sewage system. So there's a concept of structural racism, which is different from different other types of racism, but that's the built environment in certain areas is different. It's disparate. It is underdeveloped, poorly developed. We have poor HVAC systems in Boston Public Schools, for instance. But interestingly enough, as we've gone through the city to put bots in manholes, to pull up wastewater to surveil SARS-CoV-2 virus in the wastewater, what we found is manholes are not equal across the city. So, for instance, you can go to a suburb, a nice town like West Roxbury, a nice neighborhood, and you can find a very kind of calm, peaceful place where you can actually access, 5,000 people's worth of sewage to then kind of get a good piece of information about what's happening with the virus there. But if you want to go to other parts of the city that have been historically marginalized, are so densely populated that the only way you can get to that manhole is if you're in the middle of a really busy street, which means that you need a police detail, which means that you need to spend a lot more money. And I think these are the hidden costs of structural racism that you don't even think about until you start to dig into it, literally.
That's one I would say no one in this room ever thought about before. We don't have tons of time, but Rachel, I wanted to ask you, when you think of the problems you've so clearly described, and you see the digital innovation that we're here today talking about, what is the area where you think digital and technology can have the most impact to address these issues?
Everywhere. I mean, there's literally so many, our healthcare system is actually broken, right? So there's so many opportunities to narrow those health disparities and to provide care in innovative ways, like Simmone is doing with Poppy Seed Health. So there's so many opportunities. There's opportunities through telemedicine. There's opportunities through innovation in remote visits, remote care, getting remote information. I think there's so many opportunities that individuals, you all, I think the incorporation of health equity throughout what you do and just thinking about different populations of people that you may not necessarily normally address, I think that's where you can make a big difference in eliminating disparities. Are you even thinking about communities of color or communities that have rural communities that have poor access or poor broadband? That does not mean that they can't benefit from technology and innovation. It just means that they need to be accessed in a different way. And that's where your expertise comes into play.
Really, really well said. We have to wrap, but Simmone, I know you're very excited about something that came out of the White House just in the last 2 weeks. So could you just describe what that was and how it might help in this problem?
Yeah, and I actually think that there are some sponsors in the room for the $8 billion private sector nutrition bill that just came out of the Biden administration that we're very excited about at Poppy Seed Health, because in our top 5 categories, which should not be surprising, but I'll say them, number 1 is sex, number 2 is nutrition, Number 3 are hemorrhoids. No one talks about them when you're pregnant. It's highly stigmatized. Number 4 is loss. And number 5 is how to generally connect with your providers more and self-advocate for the things that you want on your journey. But nutrition being number 2 is across the board. It's people coming to us and saying, hey, can I have sushi? Okay, fine, we can have a conversation about it. But the majority of folks are coming to us and they're saying, hey, I can't feed my family of 4. I actually don't have access to the healthy foods that I need, and I just got my results back for gestational diabetes while they're in their 2nd trimester of pregnancy. And that's why I'm so excited about what's coming out of the administration, especially as it relates to nutrition, because I think it all goes back to emotional and mental health support anyway, and you cannot be centered if you are hungry.
And the White House also just announced funding for 13,000 community health workers around the country that will focus especially on marginalized communities. Probably will help you with your work.
Absolutely.
I'm sorry
And they expanded broadband.
And they expanded broadband.
That's
So
right.
there's a lot of things happening that add up to progress, I hope. And you 3 are wonderful activists in this arena. Sorry we don't have more time because this is such an important topic. And I have to give Drew kudos for putting this session together. And so thank you to Drew and thank you to all 3 of you for being here.